Yeah. It's 9:31. Yes, we should.
Yes. Srinivas, please take it.
Very good morning to all the faculties and dear postgraduate students. We will now start the first session of the day 3 of PediaRare 6. We have 3 speakers. Dr. Virat Galhotra will be covering vital pulp therapy in primary and young permanent dentition. Dr. Prasad Musale will be covering non-vital pulp therapy in primary dentition, including pediatric rotary endodontics. And Dr. MaheshRamakrishnan will be covering Apexification and Regeneration. So before we start the session, let me introduce the two moderators for the session. That's Dr. Nikhil Marwah and Dr. ShobhaFernandes. So Dr. Nikhil Marwah is presently the Dean Research at Mahatma Gandhi University of Medical Sciences and Technology. He is also professor in the Department of Pediatric and Preventive Dentistry, Mahatma Gandhi Dental College, Jaipur. He is Assistant Secretary in the ISPPD Member Science Committee in the International Academy of Pediatric Dentistry, Editor-in-Chief, International Journal of Clinical Pediatric Dentistry, which is indexed in PubMed and Scopus. He is also the author of the textbook of pediatric dentistry with more than 100 scientific publications in various international and national journals. Welcome, sir. Now let me introduce the second moderator, Dr. ShobhaFernandes, madam, who is currently working as professor and head at NPDCH Dental College and Hospital, Sankal Chand Patel University, Vishnagar, Ahmedabad, Gujarat. Her academic qualification includes she passed out a BDS in 1988 from Bapuji Dental College and Hospital, Davangere, and finished her MDS in October 1994 from Bapuji Dental College and Hospital, Davangere. She also has fellowship in dental education, People's University, Bhopal, Madhya Pradesh in 2023, postgraduate program in public health camp, hospital management for nursing and allied health professionals in 2025. She has over more than 60 publications in international and national journals, and she's also a reviewer in various national journals and has done several presentations and chairing sessions at the national conference. Welcome, ma'am. Now I request Dr. Nikhil Marwah to please introduce the first speaker of the day, Dr. Virat Galhotra.
Hello everyone and a very good morning. First of all, let me congratulate ISPPD and
Nikhil, sir.
Am I audible? Yeah, am I audible?
Yes, sir, you're audible. Please go ahead.
Yeah. So let me first congratulate ISPPD for this great effort which they are doing for the postgraduates and the entire team who's taken time out amongst their busy schedule to do this particular activity. And welcome to all the speakers and all the moderators for this session. And it gives me immense pride to introduce the first speaker and my dear friend Virat. We've done a lot of good and bad things together, and I'm sure he'll teach you all very good things today here. So he's an alumni of David Dental College and Manipal, and he's currently as professor and head in dentistry at AIMS Raipur. He has many publications and textbook contributions to his name along with patents. And his special area of expertise, I remember ever since his postgraduate days, is endodontics. So I'm sure he's going to give you a plethora of information for that. And he's been awarded as a Star Periodontist Award and has been associated with the Journal of ISPPD and other journals also in various capacities as associate editor and also a lot of other academic and research oriented activities. Virat, I welcome you and I hope that all of you have a great session listening to him.
Thank you, Nikhil. Thank you. And good morning, all. And first of all, I thank Dr. Madhu and his team to organize such a beautiful event, and especially for PGs. Let me share my screen. Am I audible to all?
Yes, yes.
Yeah.
Yes, sir. It's clear.
So today's topic is vital pulp therapy in primary and permanent teeth. These are some of the questions asked in previous papers. You can have a look.
Sir, please make it full screen.
It's full screen from my side.
Yeah.
It's not. Yeah. Okay.
I think it's in presenter's view. You can just make.
Presenter. Okay. Let me see. Is it now?
Not visible.
Wait. Let me see. This, yeah. Is it fine?
Yeah,
Yeah.
it's fine, sir.
Perfect.
So these are some of the questions asked previously in various question papers. So coming to the introduction, vital pulp therapy encompasses a range of treatment procedures designed to maintain vitality of pulp tissue that has been compromised by caries, trauma, or iatrogenic factors. The basic fundamental principle is the removing of the diseased or contaminated pulp tissue while preserving healthy tissue to maintain vitality and function. The scope of treatment ranges from minimal intervention in IPC to more extensive procedures like full pulpotomy and is applicable to both primary and permanent teeth. The clinical significance lies as it prevents premature tooth loss and associated sequelae, and it preserves the masticatory functions and aesthetics. It also reduces the need for complex space management procedures. The biological basis behind VPT procedures is inherent capacity of pulp to heal and regenerate under favorable conditions. This is assisted by abundant vascular supply, rich cellular diversity, local and systemically derived growth factors, and inherent dental pulp stem cells. How does the healing progresses? The healing in the immediate phase, there is hemostasis and initial inflammatory response, which occurs within 0 to 48 hours. In the next 2 to 7 days, the inflammation resolution of the inflammation occurs and cellular migration happens. Then comes the proliferative phase, in which the angiogenesis and tissue organizes. And last is the maturation phase, which is within 1 month to 6 months, wherein the hard tissue barrier formation occurs. The factors affecting the treatment success. The first factor is the age of the patient. The younger the age, better is the healing. The pulp vitality status is the second factor, wherein the preoperative positive response to sensibility testing, minimal bacterial contamination, and a pulp capping and a restorative sealing material of good quality influences the overall treatment success. History dates back to 1956, when Philip Pfaff first introduced pulpotomy procedure using cauterization and gold foil. Later in 1820s, Spooner introduced the use of morphine for pulp treatment. And then in 1904, Buckley developed the formicazole technique for pulpotomy. The earlier concepts were focused on mainly pain relief rather than regeneration, owing to the limited knowledge of pulp biology. With the more histological evidence and coming in the later part of 20th century and in the introduction of biocompatible materials, the focus shifted to regenerative pulp therapeutic procedures. These bioactive materials such as MTA, biodentine elicit a biological dentin response, and through calcium and phosphate ion release, raise in pH level and protein adsorption. Two types of dentin formation occurs. First is reactionary dentin, which is formed by existing odontoblast, and then is reparative dentin, which is formed by newly differentiated odontoblastic-like cells. With the introduction of calcium hydroxide in 1960s, the pulp capping was started with the introduction by Herman, and later in 1993, by 1993, MTA was introduced by Torabinajad in Loma Linda University, paved the way for various bioceramic regenerative materials, including biodentine. As per American Association of Endodontics, Vital pulp therapy techniques are means of preserving the vitality and function of dental pulp after injury resulting from trauma, caries, or restorative procedures. VPT procedures have traditionally included indirect or direct pulp capping and partial or complete pulpotomy. So the vital pulp therapy will be covered as pulp capping and pulpotomy procedures. Before going further, first step is case selection, under which the patient assessment is very important, and patient-related factors like age, consideration, level of operation, reliability to turn up for the follow-up visits is very important. Then second factor, assessment of medical history of the systemic health status like diabetes, any anticoagulants or allergies also affect the overall success rate. Then pain assessment as to duration, spontaneity, and severity can be the key factors to guide the treatment selection. The clinical signs of healthy pulp include asymptomatic or mild pulps with mild symptoms, and normal response to sensibility test, absence of spontaneous pain, normal percussion response, and pain relief immediately after stimulus removal. Let's see the signs which suggest a compromised pulp. First is spontaneous, when there is spontaneous pain or throbbing pain, when there is pain even after removal of the stimulus, then pain of percussion or palpation, abnormal mobility, presence of fistulous tract, swelling or tenderness. Coming to the clinical examination parameters, various pulp testing modalities are present. However, laser, Doppler and pulse oximetry do not have evidence and are not validated for use in primary teeth. In primary and immature young permanent teeth, most pulp vitality tests are not reliable because of the following reasons. First is pediatric patients have very low pain threshold and cannot always describe the subjective symptoms or sensitivity to stimulus. Pulp vitality tests require a response to stimulation. Hence, results can be exaggerated in young patients due to the failure of immature teeth to respond in the same manner. Majority of the children perceive vitality testing methods as unpleasant stimuli, and chances of false positive or false negative results are very common in children. Also, in primary teeth, due to lack of development of plexus of Rashko in pulp dentine complex, pulp tests like thermal and electric tests are unreliable. Therefore, they are to be used as adjuvant to other clinical diagnostic aids in pediatric patients. However, a study done by Horay in 2012 evaluated the electronic and thermal tests, in which they found that the EPT has the highest specificity of 92.5%, and heat test has demonstrated the highest sensitivity of 86.7%. Coming to the radiographic evaluation, the radiographic assessment protocol includes basically the first essential is the good periapical radiographs, and OPG and bite wings can be adjuncts to this. So for the normal radiographic, in cases of vital pulp therapy treatments, the radiographic findings which are to be checked are, first is normal PDL width, the appropriate root length of that particular age, normal root morphology and development, absence of periapical radiolucences, and intact lamina dura. As per AAPD guidelines, in cases of pulp exposure, they strongly recommend MTA or biodentine pulpotomy, where it is highlighted in the green boxes. In cases of no pulp exposure, selective caries removal and indirect pulp capping is advocated. Coming to indirect pulp capping, As AAPD defines, it is the deepest decay which is left in place to avoid a pulp exposure, and the tooth is restored to prevent micro leakage. The various indications include a deep caries lesions with a vital pulp, no pulpitis or only reversible pulpitis where the deepest layer of the caries dentin is left in place to avoid pulp exposures. The contraindications include teeth with irreversible pulpitis, necrosis, or other signs of pulp degeneration or pathological changes, and in unrestorable teeth. So, the biological rationale is based upon two-zone concept, in which the first, the outer layer is the infected dentin with irreversible collagen damage, which needs to be removed, and the affected dentin, which is the inner layer with the reversible demineralization, is to be preserved. According to International Caries Consensus Collaboration, they recommended the level of hardness as the criteria for determining the clinical consequences of the disease, and they defined three strategies. One is selective removal of the caries tissue, which includes the selective removal to soft dentin and selective removal to firm dentin. Second step is the stepwise removal, in which stage one is selective removal to soft dentin, and stage 2 is the selective removal to firm dentin 6 to 12 months later. And last is non-selective removal to hard dentin, formerly known as complete caries removal, which is no longer recommended. This is a representative case in which there is selective removal of the caries tissue and pulp capping agent is placed, and later on final restoration is done. Let's see the evidence. This is a systematic review regarding the caries removal strategies for deep caries lesion in primary teeth, published in 2020. According to the authors, and they compared the efficacy of three caries removal techniques. One is complete caries removal, selective caries removal, and stepwise caries removal. And they concluded that overall risk of pulp exposure was significantly reduced with selective caries removal and stepwise caries removal compared to complete caries removal. Coming to direct pulp capping, American Academy of Pediatric Dentistry recommends direct pulp capping in vital primary teeth where a pinpoint exposure of the pulp is encountered during cavity preparation or following a traumatic injury. Indications include permanent teeth with a small mechanical or traumatic pulp exposure when the pulp is healthy, minimal or no bleeding at the exposure site, and in immature permanent teeth where apexogenesis is done. In the contraindications, teeth with irreversible pulpitis, necrosis, or uncontrolled bleeding from the pulp, caries exposure of greater than 2 millimeter with bacterial contamination, and where there is poor hemostasis or the inability to control bleeding within 5 minutes. Coming to the biological foundation, healing of the pulp in DPC depends on maintaining the favorable conditions of repair. After initial hemostasis is achieved, inflammation is controlled, and again the proliferative phase, angiogenesis and cellular proliferation occurs, and the hard tissue formation is at the last phase, which is called as maturation phase. Clinical procedure steps. The step one is hemorrhage control, which is to be achieved with after gentle saline irrigation to remove the debris and application of moist cotton pellet with a light pressure for 2 to 3 minutes for natural hemostasis. Bright red bleeding indicates healthy pulp. Step two is the surface preparation, wherein minimal air is used to dry to avoid desiccation, and saline irrigation is done to remove any bacterial contamination, and then evaluate the tissue for color and bleeding characteristics. Step 3 is the material application, wherein MTA or biodentine is directly placed over the exposed pulp with a 1 to 2 millimeters extended beyond the exposure margin, and with a thickness of 1 to 2 millimeters. Then step 4 is the immediate restoration. Glass ionomer or resin modified glass ionomer is preferred, and the seal quality is very important since it is if any sort of leakage is there, the bacterial contamination can occur and leads to the failure of the procedure. And last is the permanent restoration. So what are the success predictors? First is exposure size of less than 1 millimeter diameter is optimal for permanent teeth and with minimal bacterial contamination, and a young patient has a better prognosis. And last is if the hemostasis can be controlled, that indicates vitality. So this is a systematic review wherein the authors check the outcomes of direct pulp capping in vital primary teeth with carious and non-cariously exposed pulp, and they concluded that DPC has a clinical and radiographic success rate ranging from 53 to 100%, and there is no support to strongly recommend a particular agent over another for DPC in primary dentition. However, safer and more biocompatible agents such as MTA, calcium enriched mixture, Emdogain, calcium sulfate, simvastatin could be better options for this pulp therapy. Another systematic review and meta-analysis on clinical outcome of direct pulp therapy, they found out that there is a significant success rate of DPC treatment with of approximately 89.9%, and this suggested that DPC should not be disregarded as the treatment option, especially in the primary teeth. Next is pulpotomy. According to AAPD, pulpotomy is the surgical removal of corneal portion of the vital pulp tissue. A biologically acceptable material is placed in the pulp chamber and the tooth is restored. The rationale behind this is after the surgical excision of the infected or inflamed corneal pulp, the vital uninfected pulpal tissue can be left behind and preserved in the root canal. AAPD laid down the objectives of pulpotomy, in which the first objective is the radicular pulp should be asymptomatic without adverse clinical or signs or symptoms such as sensitivity, pain, or swelling. There should be no post-operative radiographic evidence of pathological external root resorption or internal root resorption, and there should be no harm to the succedaneous tooth. History dates back to 1930 with the use of formopizole medicament, which aimed for preservation or regeneration, gained popularity with time, and with the introduction of MTA, focus shifted to regenerative pulpotomies. The indications include carious pulp exposures, wherein the 2/3 root length is there and no signs of periapical lesion is there on the radiograph, and no radiographic signs of pathological resorption, and bright red and red color of bleeding is there, and hemostasis is achievable within 5 minutes. The contraindications include any evidence of internal resorption in teeth near close to the exfoliation, any sort of abscesses, intraradicular bone loss. Treatment objective includes the amputating of the infected corneal pulp and preserving the vitality of the radicular pulp, and the remaining pulp is to be treated with the medicament. Really classified pulpotomies according to the treatment objectives into vital pulpotomy, which is further subdivided into devitalization, preservation, and regenerative, and a mortal pulpotomy. So it can also be divided as single visit pulpotomy, 2-visit pulpotomy, mortal pulpotomy, or partial pulpotomy. First is partial pulpotomy, can be for carious exposure and for traumatic exposures. For caries exposures, the inflamed pulp tissue is to be removed to a depth of 1 to 3 millimeters or deeper to reach healthy pulp tissue. It is indicated wherein the caries pulp exposure in which the pulp bleeding is controlled within 5 minutes for primary or 6 minutes for young permanent tooth. The tooth should be vital, normal pulp, or with a reversible pulpitis. And the partial pulpotomy for traumatic exposures, also known as freck pulpotomy, the inflamed pulp tissue beneath an exposure that is 4 millimeter or less in size. Indications include vital, traumatically exposed young permanent tooth with an incompletely formed apex. This is a representative case of partial pulpotomy in 8-4. After isolation, caries excavation, the pulp is exposed, hemostasis is achieved, then MTA is applied with then glass ionomer cement base is applied, and finally composite restoration is done. This is a representative case for full coronal MTA pulpotomy in 8-5. After isolation, caries is excavated, pulp is exposed, hemostasis achieved, MTA application done, GIC restoration, and final restoration is done with stainless steel crown. Various pulpotomy medicaments have been introduced into the market. We'll be just seeing few of them. First is formoxazole pulpotomy. Formoxazole has been used in dentistry for over 100 years and for vital pulpotomy in primary teeth for over 80 years. Its efficacy has been extensively studied with clinical success rates ranging from 70 to 100%, making it the standard against which newer techniques are to be compared. It was introduced by Buckley in 1904. Then Sweet in 1930 introduced the multiple visit technique. Later, two-sitting procedure was given by Doyle in 1962. Spedding gave the 5-minute protocol in 1965. And Wenham in 1967 gave the 15-second procedure. The mechanism of action is based on it causes the coagulation necrosis in the tissue in immediate vicinity of the application with fixation of the tissue cells and microorganisms. Histologically, it forms 3 distinct zones. First is a broad eosinophilic zone of fixation. Second is a broad pale zone of poor cellular definition. And last is zone of inflammation diffusing apically into normal pulp tissue. The advantages include it is commonly available, it is stable at room temperature, has a long shelf life. However, it is toxic in high doses. Potentially, there is systemic absorption, and it is mutagenic and carcinogenic in nature. So, answer, sir. Coming to laser pulpotomy, it has hemostatic, antimicrobial, cell-stimulating properties with only slight thermal alteration to the pulp tissue. In recent years, the application of lasers has been recommended in several endodontic aspects, including treatment of dentinal hypersensitivity, pulp capping, sterilization of root canals, root canal shaping, obturation, pulpotomy of primary teeth as an alternative to the conventional formoxazole. The mechanism being the laser irradiation increases the creation of calcified nodules in human dental pulp fibroblasts as well as collagen and osteocalcin synthesis. It increases the alkaline phosphatase activity. Laser irradiation creates a superficial zone of coagulation necrosis that remains compatible with the underlying tissues and isolates the pulp from subways. Coming to the preservation pulpotomy, glutaraldehyde, it was proposed in endodontics by Gravenmaid in 1975. Later, in 1975, it was proposed in pulpotomy by Ranelli and Lazare and proposed by Koppel in 1980 to be used in humans. The various properties of glutaraldehyde are, so it has a superior fixative properties. It is self-limiting penetration. It has low antigenicity, low toxicity, and there is elimination of cresol from this. Atkinson's described the two zones of pulp after glutaraldehyde application. First is zone of fixation and zone of pro-inflammatory fibroblast. Advantages: it is initially more active chemically, it rapidly forms cross linkages, and its penetration is more limited. There is no evidence of ingrowth of granulation tissue into the apex in the glutaraldehyde treated specimens, and there is less apical damage and less necrosis in the glutaraldehyde treated specimens. Glutaraldehyde is not as volatile as farmakazole. Disadvantages include it has a short shelf life, it has to be freshly prepared, and the buffered solution has to be refrigerated. Neither the optimum time nor the application time has been established. Next is ferric sulfate pulpotomy. Ferric sulfate is a non-aldehyde chemical which has been used commonly as an astringent. Ferric sulfate as a 50.5% solution is coagulative and local hemostatic agent. Fee et al. Reported the application of ferric sulfate in pulpotomized human primary molars with a clinical and radiographic success rate of 100 and 97% respectively. It promotes pulpal hemostasis through a chemical reaction with the blood. Ferric sulfate is a material with minimal devitalization and does not cause fixation of the dental pulp. Mechanism of action includes it is a heavy metal salt, causes agglutination proteins in the peripheral capillaries and helps in the formation of blood clot. The precipitated metalloprotein complexes clogs the blood vessels and acts as barrier to irritants of ZOE base, thereby promoting healing in the remaining radicular pulp. Coming to the regenerative pulpotomy, first is calcium hydroxide pulpotomy, recommended in 1938 by Tushar and Zender. However, it demonstrated necrosis of pulp lying close to calcium hydroxide and secondary dentin formation. It forms three distinct zones. First is coagulation necrosis, and second is deep staining basophilic areas of varied osteodentin. Third is relatively normal pulp, which is slightly hyperemic. However, according to AAPD, use of vital pulp therapies in primary teeth with deep caries lesion is recommended against the use of calcium hydroxide for pulpotomy. Coming to MTA pulpotomy, MTA was introduced by Mohammad Torabinajad in 1993. It shows a high alkaline pH, but as it is not affected by leaching, provides better sealing ability. And gray MTA causes staining of the crown. However, newer forms are available in the market with limited discoloration. This is the basic difference between gray and white MTA, in which gray MTA contains a tetracalcium aluminoferrite, which is responsible for gray discoloration and causes the discoloration of teeth. The ferrous oxide is replaced with magnesium oxide, and hence no tooth discoloration is there in white MTA. Gray MTA has larger particles, whereas white has smaller particles with narrow size distribution. Gray MTA takes longer setting time, and there is shorter in white MTA. Then it has a greater compressive strength in comparison. Gray MTA has a greater compressive strength in comparison to a white MTA. Mechanism of action includes MTA releases calcium ions, which is higher, which is alkaline in pH and inhibits bacterial growth. It reacts with tissue phosphates to form hydroxyapatite. Then absorption of serum proteins and the growth factors. They promote the adhesion and proliferation of mineral tissue forming cells, and then the mineralization of hard tissue occurs. It also promotes cellular migration, differentiation, upregulation of cytokines, bone morphogenic proteins. MTA, regarding the properties, it has high biocompatibility, bioactivity. It is hydrophilic in nature. It is less toxic than calcium hydroxide and has a good sealing ability and promotes regeneration of PDL, dental pulp, and periradicular tissues. Coming to biodentine as pulpotomy medicament. Biodentine is a new generation material based on calcium silicate synthesized by bioactive technology. Biodentine stimulates release of TGF beta from pulpal cells, stimulating reparative dentin formation in a very short period of time. Particular growth factors from TGF beta family have the ability to initiate odontoblast differentiation and hence produce tertiary dentin by cell signaling. Biodentine is both a dentin substitute base and a cement for maintaining pulp vitality and stimulating hard tissue formation. It offers advantages over calcium hydroxide in a way that it is stronger mechanically, it has less resorption, and it produces a tighter seal. That it needs less time for setting than MTA. Biodentine is sufficiently stable to be used for pulp protection. Coming to the evidence, this is a systematic review and meta-analysis in the comparison of biodentine and MTA for primary teeth pulpotomies. 9 studies were included, and after the inclusion and exclusion criteria, the authors concluded that MTA was considered as the gold standard for pulpotomy procedures. However, the pooled relative risk for clinical and radiographic success does not show any significant difference between the two materials at 18 months interval. Hence, biodentine can be considered as a viable alternative to MTA. Newer alternatives and natural alternatives, there are many in the market, and everybody is doing a lot of research and a lot of theses are coming up. We'll stick to the gold standard one and we'll come to the evidence now. This is an overview of systematic reviews regarding the success of medicaments and techniques for pulpotomy of primary teeth, done by Nitesh Tiwari et al., in which 8 systematic reviews were included, in which they have higher overlap of primary studies across the meta-analysis was present. All the medicaments or techniques achieved greater success rate of greater than 80%. MTA was found to be superior to calcium hydroxide and formoxazole over a longer period of time, that is greater than 18 months follow-up. Then when compared to formoxazole, all the medicaments except calcium hydroxide achieved acceptable greater than 80% success rates. Comparative factor which needs to be evaluated to determine the success are the long-term radiographic outcomes and pulp preservation. This is again a systematic review and meta-analysis of primary tooth vital pulp treatment interventions published in Pediatric Dentistry in 23. 299 studies were analyzed. IPC was considered as gold standard with success rate of 97%. Different aligners, capping agents had no significant effect on the success. There was no significant difference between MTA versus biodentine. Both are significantly better than direct pulp capping and other pulpotomies. When MTA and biodentine pulpotomies were compared in these studies. Then IPT and pulpotomy were equally effective for appropriate cases. Regarding the formoxazole and MTA, the evidence supports moving away from formoxazole. The same is with the ferric sulfate. However, the performance was slightly better, but significantly inferior to MTA. Regarding the caries management strategies, selective versus complete caries removal. Selective or stepwise removal was significantly better at avoiding pulp exposures versus complete excavation. So the key take home messages are vital pulp therapy preserves natural tooth structure. Proper case selection is crucial for success. Modern bioactive materials offer superior outcomes. Regular follow-up to 18 months is essential for monitoring success, and evidence-based protocols should guide the treatment decisions. Thank you.
Thank you for the presentation, sir. So there are a few questions which the students have asked.
Good.
The first question is how diabetes will affect vital pulp therapy.
Yeah, diabetes, when it is uncontrolled
The
diabetes.
voice is mute.
No, it's open. It's not mute. Am I
Yeah,
audible?
now it's audible.
When diabetes is uncontrolled, the wound healing, it is affected. Same is the case when in such cases where the type 1 diabetes, you have a poor success rate. DPC, second question is DPC indicated in primary tooth. DPC is indicated in a particular scenario wherein there is a traumatic exposure as EPD, otherwise it is not recommended. It is rather contraindicated due to internal resorption.
And a question that's asked is what happens to the remaining pulpal tissue after pulpotomy?
How often? Nice. You are in the last question, not somewhere, because I am at third question.
So there are a few questions which you have already answered in the slides.
Okay,
You have asked it again.
Okay.
What is not shown on the slides, I'm asking.
Okay. So, yeah, can you repeat the question?
What happens to the remaining pulpal tissue after pulpotomy?
So it is basically the pulp has to regenerate by the growth factors. That is the ideal way, but we are still, we could not find the ideal pulpotomy medicament. So the quest for finding newer materials is there in the market.
And one more question is controversies pertaining to pharmacrosol pulpotomy. They've asked for the references. I think references can be posted later.
We'll send across.
And reference material for pediatric endo controversies. That's again, they have asked for references, which I think we can post it later in the website.
Yeah, we'll post it.
So one last question is, can laser pulpotomy be done in hypoplastic pulpitis?
Yes, it can be done.
I think we have covered all the questions except for those which you have already covered in your slides, sir. I think that's done.
Right.
Now I request Mr. Dev to please project the certificate of appreciation to Dr. Virat, sir.
Thank you.
Thank you, sir.
Thank you very much. Thank you.
Now we'll be starting with the second speaker of the day, Dr. Prasad Musaleapexification, sir. I request Dr. ShobhaFernandesNon-vital ma'am to please introduce the speaker.
Thank you so much. I hope I'm audible.
Ma'am.
Thank you so much for this opportunity to the organizing members and a very nice session so far. Congratulations on a well-conducted program. It's a pleasure to introduce Dr. Prasad Musale. He has graduated BDS in 1994 and completed his pediatric and preventive dentistry in 1999. He also additionally has a diploma and master's degree in laser dentistry from the Medical University of Vienna in Austria in 2010. Following his completion of educational tenure, he has established his clinic, Little Ones, Big Smiles, at Koregaon Park, Pune. His research interest areas are pediatric endodontics, microscopic pediatric dentistry, minimally invasive dentistry, and laser-assisted pediatric dentistry. He's an international speaker, well-known, a faculty who has conducted several CDE programs globally. He also has published several scientific articles in international and national journals. He's contributed 5 chapters to pediatric dentistry textbooks. He's recognized by various international journals and honored as editorial board member and also as a reviewer. He's currently professor and head of pediatric and preventive dentistry at SMPT Institute of Dental Sciences and Research, Nasik, India. Welcome, and we look forward to a very interesting session by you, Dr. Prasad.
Hello, is it visible?
Yes, sir, it's visible.
Okay.
You have to make it full screen, sir. Yeah, done.
So I'll be speaking today on non-vital pulp therapies in primary dentition, including pediatric rotary endodontics. These are the questions which are generally asked, and these are from different question papers till now. Non-vital pulp therapies in primary teeth, rotary endodontics in primary teeth, describe various shaping techniques in primary teeth, describe cleaning protocol in primary teeth pulpectomy, describe the various obturating techniques in primary teeth, describe various obturation materials in primary teeth, pediatric endodontics yesterday, today, and tomorrow, and non-instrumental endodontic therapy in primary molars. So basically, a non-vital tooth is also known as a dead tooth, where the pulp and the soft tissue at its core containing nerves and the blood vessels has died. The causes of non-vital tooth are injury or trauma. A physical blow to the tooth can damage the pulp, cutting its blood supply, or untreated cavities can penetrate through the dentine, leading to infection and non-vital tooth. Symptoms are sensitivity to temperature and changes in tooth color, often darkening to yellow, gray, or black view. You can see in the picture where the right side central incisor is discolored. The consequences are non-vital tooth is more susceptible to infection, which can spread to the jawbone and surrounding underlying permanent teeth. Treatment indicated is pulpectomy. Now, the classification of pulpectomy is it can be either instrumental or non-instrumental endodontic therapy, or it is called as NIET, or it could be partial and complete. Now, AAPD defines pulpectomy as complete removal of the pulp, nerve, and the other tissues from both crown and the root canals. The canals are cleaned, shaped, disinfected, and filled with resorbable biocompatible material till the time tooth exfoliates. Now, first I will start with the non-instrumental endodontic treatment, or NIET. It is also called as lesion sterilization and tissue repair, or LSTR. It is a new biological approach introduced way back in 1988 in University of Niigata in Japan, developed by Chirurgy Research Unit of that university, and it suggests placement of without removal of the pulp and periapical involvement using the mixture of 3 antibiotic paste in the form of ciprofloxacillin, tetracycline, and metronidazole. Now we know the side effects of tetracycline, so it has been replaced with clindamycin. So you have combination of ciprofloxacillin, tetracycline, and metronidazole mixed freshly, and it is mixed with propylene glycol or macrogol. Now these antibiotics have to be mixed in propylene glycol or macrogol on the spot, that is freshly. Indicated in extremely uncooperative young children where conventional pulpectomy is not possible. So it is not something which is very strongly recommended, because we don't find a lot of good evidence in terms of repair of the bony lesions. So this is the schematic representation. In the diagram, it shows the number 3 is, number 1 is the restoration, number 2 is the capping agent, number 3 is the test cavity preparation, and that is at the orifice of the canal, and where the antibiotic paste is placed over there. And then the restoration is carried out, and the tooth is followed up over a period of time radiographically and clinically. Now, as far as non-vital teeth diagnosis is concerned, most of the times it is pretty simple. It is in the form of an abscess, which you see in this picture over here, intraoral picture, and the same tooth radiograph, it shows the furcation area where there is bone which is showing a radiolucency, which shows there is a loss of furcation bone. Also, it shows the loss of cryptic lining. Now, why do you want to save the tooth? Because it is well mentioned fact in the literature that natural or well restored teeth are the best space maintainers, and that's why you should think of doing pulpectomy as a standard procedure. The indications are very simple: healthy and cooperative patient, restorable crown, extension of pulpotomy. I will explain about this point little later. History of spontaneous pain, that means pain in the night, especially nocturnal pain, and it has been a recent episode. Initial level of ERR or IRR in the radiographs, pulpless primary teeth without permanent successors, and pulpless primary second molars before eruption of the first permanent molar. So these are the indications which are given in standard textbooks.
Prasad?
Yeah.
On this presentation, I think there is a virtual rare 6 is written.
Yeah.
And this is coming on the text actually. So that's why I think our audience is not able to see the text. Is it quickly possible for you to remove this background? If it is possible. If it is not possible, then go ahead.
Sir, it's only some slides because there's virtual rare, it's written in the dark color. And
That's why it was coming on to some text, and that is why I think people are not able to read it. But if it is on some slide, that's okay.
PDF anyways, so they will be able to see it, sir.
Yeah, perfectly fine. Sorry for interruption. Please carry on.
No, sir, no problem, sir. So this is what I was talking about. Dr. Virat has already explained. If you see the case number 1, left side video, you will see that the bleeding is controlled, the pulp is nice. So that is indicated for pulpotomy. On the right side, there is still oozing from the distal canal, which suggests that pulpotomy is not going to work in this case, and you need to think about removal of the further pulp from the radicular part. So that is indicated for pulpectomy. But these are both vital teeth. The contraindications are very, very important. And the first one is the interrupted crypt lining, which you can see over here. See the arrow over here. You can see the cryptic lining, which is bony covering of the permanent tooth bud, that is destroyed because of the infection. So you should be cautious about selecting such cases. Then the crown, if the caries is subgingival, as you see over here, that suggests that if the tooth is not restorable with the crown, then it is not indicated for doing a pulpectomy. You better go for extraction and space maintainer. The next contraindications are advanced IRR, that is internal root resorption. You can see it is perforating over here, and here also it could be perforating. And also advanced ERR or external root resorption, where one of the distal root is resolved because of the external resorption, that is also secondary to the infection, long-standing chronic infection. And the last contraindication is the primary teeth with underlying cyst. Here you can see the periapical cyst, huge periapical cyst where the premolar has been pushed down towards the lower border of the mandible. So these teeth are indicated for extraction and not for pulpectomy. Now, as far as working length determination is concerned, I want you to understand certain terminologies. I am going to touch the basics again. The tip of the root is the radiographic apex, what we consider, where the pulpal exit is there at the apical area, that is called as the actual apex or apical foramen, and the working length is generally 1 millimeter shorter than the actual apex. So generally we depend on radiograph, but it has been shown recently in many studies that apex locators are very, very useful and they are working regardless of the stage of resorption. The other advantages are it is very quick and there is reduced radiation exposure. But you have to make sure that you underestimate the root canal length by 0.98 mm or 1 millimeter than the actual length, and that is the most accurate one. Now, just to prove you that radiographs can be misleading, here you can see on the left hand side in the two-dimensional radiograph, you can see that the file is within the confines of the canal. But the clinical picture, the yellow arrow, which shows on the right hand side picture where the file is 2 millimeters beyond, 1 millimeter to 2 millimeters beyond the apical foramen. So it is, though looking X-ray on the X-ray that it is within the confines, it is actually not. And the white arrow shows the actual apical foramen. So your working length should be 1 millimeter shorter than that. And that is why the radiographic length is not a good option. What happens is that once the file goes beyond, you are creating an unwarranted path where the irrigant as well as the obturating paste is going to go. And that will pose imminent threat to the underlying permanent tooth bud. Underlying premolar may be hypoplastic. Overfilled zinc oxidizonol may deflect the eruption path of the premolar. So these are the problems if you don't use the apex locator. So you start using the apex locator and make your life easy. Also, I want to stress that the primary root canal taper, natural taper of the primary molars root canals is 4 to 6%, especially in the anterior teeth. It is more than 6% many times. And as far as the molars are concerned, it is 4 to 6%. And this has been proven in our study. So it indicates that we should start using rotary files more often than ever, and we should be able to do pulpectomy successfully. Now, the advantages of the rotary shaping. The first advantage is better cleaning efficacy. Now, this is a study by one of my very dear friends, Dr. Zafer Ali. He's from Turkey, and it is a microcomputed tomographic assessment of root canal preparation with conventional and different rotary files in primary teeth and young permanent teeth. It is published in International Journal of Pediatric Dentistry 2019. It shows the green, the baseline is the green uninstrumented areas. You can see in spite of using the rotary files, there is hardly any instrumented areas, which is red. And this is coronal, middle and apical thirds, where you can see the red is very, very less. So there is not much of contact of the rotary files with the surface. So you should be keeping this thing in mind. This also offers the advantage of preservation of original canal anatomy. So original canal anatomy is maintained. It also gives a continuously tapering uniform shaping, which offers a good cleaning efficacy or good disinfection. At the same time, the obturation becomes much more easier because using some form of paste for obturation of the root canal system. Again, this reference is from one of our articles, which is presented in published in European Archives of Pediatric Dentistry 2014. It also reduces apical transportation. I have already shown you this X-ray and the three-dimensional picture. So this is what you need to keep it in mind. Please read this reference, which is very good reference from another friend of mine, Dr. Ahmed HMA. He's from Malaysia, and it's a very good article. Though he is an endodontist, he has published a lot of articles on deciduous teeth root canal treatment or endodontics. It also maintains, the rotary file also maintain the centricity, that means canal centering ability. Now, generally, when the rotary files are used for enlargement, the narrow files are preferred as compared to the wider taper files. So 4% is better than the 6%. NiTi rotary files are considered to be better than stainless steel hand files, which is provided by the article of Dr. Fareen Kadge and her colleagues. Heat treated files are better performing than NiTi files. Now, the advantage of rotary files, the most important advantage for me as a clinician is reduced working time. It gives me less fatigue. There is a better child cooperation because you finish your procedure very fast. The parents are very happy because the appointment was shorter, and you obviously can accommodate more amount of patients. So your earning is better because there is more productivity. So all these advantages are great. Now I'll come to the armamentarium for rotary endodontics. You require endomotor, you require rotary files, any rotary file systems, then you require apex locator, and you also require a handheld lens, the common lens which you use it, and it should be minimum 2.5 to 3x lens. Now the first generation endodontic motors are speed reduction handpieces. This is what I have been brought up as an pediatric dentist and endodontist, pediatric endodontist over a period of time. The problem is that there is no speed control, there is no torque control, there is no auto reverse, there is least tactile sense, but it is great for beginners because it is inexpensive and it is good to begin with. The second generation endodontic motors are electronically controlled. These are much more sophisticated as compared to the first generation. They are fully programmable. The speed control is there, torque control is there, auto reverse is there, but there is no integrated apex locator. It has a better tactile sense, but still it is with the cord. And the third one is the third generation endodontic motor, which is battery powered, which is cordless. It moves in rotary as well as reciprocating movements. It is fully programmable. Speed control is there, torque control is there, auto reverse is there. It is also having integrated apex locator, and it has the best tactile sense because there is no wire connected. It is totally wire free. Now, as far as rotary files are concerned, if you want to use the permanent teeth rotary files, you can use any file system, which is 21 or 25 mm. 25 mm is generally not required for deciduous molars or deciduous anterior. 21 mm is more than enough. Or you can use the rotary files which are specifically introduced into the market. Many of the Indian inventors are there, and they are 16 or 17 mm long, and they are also a good option as far as rotary instrumentation in primary teeth is concerned. Now, there are shaping techniques. The first shaping technique, which is called as standardized technique, which is introduced by the great endodontist Dr. Engel. It is to establish working length hand files, normal K files or H files in clock winding motions from 15 to 20, 20 to 25, 25 to 30. And 30 is the end size which is required in terms of the apical preparation. The final shape is the master apical file, which is the last file used with this. The same technique can be used with pro-taper files or M2 files. The drawback is in curved canals, final shape could be larger than the file size, and that is because of the stiffness of the files. Now, the other technique which is more commonly employed for shaping is called as step back technique. It was introduced by Klein and Wen. Stepwise reduction in working length with larger files, typically 0.5 to 1 millimeter steps. So every time you're going to come out 0.5 to 1 millimeter shorter, and resulting in flared shapes with 0.05 to 0.1 taper respectively. Apical 1/3 prepared to the size 25 to 30 and consecutive larger size files further coronally. Final refinement and shaping with master apical file. That will also take care of tapering the canal nicely to the apical foramen. less aberrant preparations in curved canals. So this is strongly recommended in curved canals. The next technique was introduced by Gorick in it is called as crown down technique, where coronal shaping first is prepared before the apical one. So coronally you are flaring the canal. Advantages is straighter access to the apical region because we are dealing as a pediodontist with the curved canals many a times. So this is of great advantage. There are no coronal interferences, removes the bulk of infected dentine and pulp tissue before apical shaping, more contact of irrigant to the wall and vest, and the working length is less likely to change, less chances of instrument separation. It prevents piston in cylinder effect, thereby eliminating debris extrusion. So whether you're using hand file or rotary file, there is always going to be a little bit of debris extrusion. So that is definitely prevented with this technique. So this technique is very popular and strongly recommended. There is another technique which is called as a hybrid technique. It is hybrid techniques actually, where the glide path is prepared with the hand files. I will come to what is glide path. Greater taper files are used for coronal flare, for example, SX file of the ProTaper system. Lesser taper files for apical shaping. Example is S2 and F1. Combination of different rotary systems for coronal and apical shaping. Least chances of file separation. So again, this is a good technique to use on the regular basis. The critical protocols are access preparation, orifice finding, patency to negotiation, glide path establishment, and rotary shaping. Now I'll go one by one. Access opening, maxillary central incisor. If you see the cross section of the maxillary central incisor, this is a cross section of the maxillary central incisor. And if you see the crown and the root, they are at an angle. They are not in straight line. So what happens is that if you take a conventional access for access, if you take a palatal access, what happens is that, and you use the rotary file, it is going to cause labial perforation or stripping. That's why the labial approach is recommended. And this is given in Dr. Muthu and Dr. Shivkumar's Pediatric Dentistry Principles and Practice 3rd edition in chapter 41. And here you will get the straight line access with the rotary file to the apical area, and it becomes much easier option. Now make sure if you're taking a labial access, it will be 2 mm incisal edge is left intact. Okay. And the advantages are it is giving a better visualization. It maintains the pericervical dentine, which maintains the long-term standing of the tooth in the patient's mouth. Straight path of rotary preparation. You get a straight line path for rotary preparation. It is easy to restore and repair because it is labially located. Labial discoloration is minimized because you can keep on repairing it. At the same time, your restorative material will be covering the maximum area on the labial surface. Now the ideal access preparation should be giving you visualization of the entire pulp chamber, facilitate identification of all canal orifices, allow straight line path for shaping, allow thorough debridement and cleaning, remove minimum but necessary tooth structure. Now, Oscan G et al. And their article, which is published in Acta Odontologia Scandinavia in 2016, you can see canal orifices and canal locations. So this is class 1 in the maxillary molar is 3 separate orifices. Class 2 is the distal buccal and the palatal are combined. Class 3 is again similar. 2 different orifices, but they may be joining. Class 4 is 4 separate canal orifices and 4 separate exits. As far as mandibular molars are concerned, class A is 2 mesial and 1 distal. Class B is 2 mesial combined and 1 distal. Class C is 2 different specific separate mesial locations and 2 separate specific canals in the distal root. And class D is mesially, it's a single canal, and distally there are 2 separate canals. So this is a very important classification which you can remember. Now, as a postgraduate student or as an undergraduate student, you must remember that a burr drop will be felt only when the pulp chamber is at least 2 millimeters deep. And at the center of the extracted primary first molar over here, mandibular first molar, you will see the pulp chamber width in the center is almost about a millimeter, not more than that. But towards the periphery, it is much more longer, and it is 2 millimeter, more than 2 millimeters. And there you will feel the burr drop, not in the center of the tooth. So initial approach, never take it from the center, because you are not going to feel the burr drop, because the pulp chamber is shortest in that area. But if you go towards the periphery, towards the pulpon, you will get a good access opening. So first step is imaginary visualization or three-dimensional visualization in your mind, how the access opening shape is going to be. Then you are going to use SF41 or a small size round burr to get an initial burr drop. After that, along the imaginary visualization which you have done and the line with this shape-ended cutting burr, you will start removing the roof of the pulp chamber. This is the roof of the pulp chamber where it is removed completely and it comes out in one piece. And then the first medicine without putting any file is 1% sodium hypochlorite as per AAPD guidelines, and just flood the pulp chamber with 1% sodium hypochlorite, leave it intact in that place for about 2 minutes, 2 to 3 minutes. And after 2 to 3 minutes, once you dry it, you will see something called as a dentinal map, where there are darker areas, which is like a map, and you can join those darker areas and you will get your access opening. At the corners of this dentinal map triangle, you will get the orifice openings of the particular tooth. Over here, this is what I was telling you about, 1% sodium hypochlorite. Leave it in the pulp chamber for 2 to 3 minutes after access opening is completed. And you will see a lot of effervescence, dissolution of the pulp tissue, flocculation of the debris, and you will see now a dentinal map, which is rectangular over here, and you will see the root canal orifices at the angles. Also, the root canal orifices can be located with endodontic explorer like DG16 Explorer. So this is mesiobuccal, this is distobuccal, and this is parietal for the maxillary molar. The next step is, once you know where the orifices are, is negotiation to patency, where I would prefer to use 10 number K file. So here you have found one mesiobuccal canal. And if you're working under magnification, you will find one mesiobuccal 1 and sometimes even mesiobuccal 2. So finally, I could find in this particular molar 3 mesiobuccal canals. So it is possible if you use the magnification. The same tooth on the distal side, initially I could locate 2, and then with a little bit of more efforts, I could find the third orifice also. Now they are connected very closely and there is formation of dentine in between. So many a times you will get one particular canal which is larger. Say for example, over here is distobuccal main one. Then there is distobuccal 1, distobuccal 2, which will be accessory and little smaller ones. Now I was telling you about the glide path. Glide path is reproducible smooth tunnel from canal orifice to the apical terminus. This is the area which you are going to shape. And this is must for rotary files using, and the minimum size recommended is super loose 10 number K file. Maximum size recommended is 15 number to 20 number K file. Glide path problems. I'll tell you all these problems. Most important statement is glide path implementation is as much a mental game as a mechanical one. Remember the importance of this. Now, this number 1 figure shows where there is a debris which is collected at the apical area, and that is not allowing the working length estimation correctly. So make sure that you don't push the debris apically. Second diagram shows where there is the curvature which is not matching the curvature of the canal, and that is why your file is not reaching to the apex. The third one is where the apical diameter is larger than the canal size, and that is why it is unable to proceed further. If the shaft diameter is larger than the canal diameter, then obviously the file will not go to the working length. So all these problems which you need to anticipate and select the appropriate file. The reference which I have given is from Dentistry Today, September 2010, way back, where it is the endodontic glide path secret to rotary safety. It's a very good article. You read it and you will find it very easy to implement. And then we come to the shaping, which is shaping is the only one. It can only lead to success. Now, manual shaping, what we have been trained as postgraduate student with K files or H files, and this is as laborious as pulling a car. The simple chart to differentiate between manual and rotary instrumentation. To save the time, I'll go faster. Now, the rotary file also allows us apical gauging. Now, if you're using rotary file or not, you need to use the size 25 or 30 at the apex to shape so that you will be able to clean it well as well as fill it well. This is recommended. So this is the key to successful endodontics. Apical gauging does cause a lot of failures, especially in permanent teeth. Now, average root canal sizes for primary teeth, this chart is very self-understanding. You will get in the PDF later on, but I will give you the reference why I am suggesting this chart. Also, rotary files give canal centering ability, which is better with 4% as compared to 6% files. So don't start using 6% files or the larger taper files for primary teeth. Always stick to 4%. NITA rotary files are better as compared to stainless steel files. This I have already covered. Now I'll come to the cleaning protocol or disinfection protocol. 1% sodium hypochlorite drop by drop intermittently throughout the shaping, only with side-vented needles. Remember, don't use the needle which is used for injection. Please use the side-vented needle because you are very unlikely to push the sodium hypochlorite beyond the tip of the root. And that can cause necrosis and damage to the permanent tooth bud. Then after that, you use normal saline to flush out the sodium hypochlorite, which is there inside. Then you can remove the smear layer by using 6% citric acid solution. Leave it in the canal for about 1 minute. And then again, wash it, flush it nicely with normal saline. And then at the end, final rinse before obturation is done with 2% chlorhexidine gluconate. This is used for substantiity, and that will give you a substantial long-term antibacterial effect in the canal. Now, saline after each irrigant is must because if you use sodium hypochlorite with EDTA, it will form something called as parachloroaniline, which is a cancer-causing carcinogenic agent. So be careful. If you use sodium hypochlorite followed by citric acid, it will release chlorine, and that is a toxic gas which everybody knows. So you start using saline after every medication which you have used without filling. Now, the protocols which you can use for rotary shaping, this is the one which is ProTaper Universal File, which I have recommended in my 2 articles which are published in the references which are shown below. Negotiation to patency, you have done it with the 10 number K file. Then 15 number K file to the working length, you will establish the glide path. Then final shaping of the smaller canals. That is why I give you the chart. What is smaller canal, what is medium size canal, and what is larger canal. So smaller size canal is for the mandibular molar is the mesiobuccal and mesiolingual. And the distal canal is going to be the larger canal if it is a single canal. So final shaping for the larger canal is done till F1. So that is how you will select it. Then I also recommend to remove the shelf of dentine, which you can see in the extracted primary molar with the help of orifice opener. In the ProTaper file system, it is SX. So to explain, the mesiolingual canal in the mandibular molars and the distobuccal canal in the maxillary molars is more likely to show shelf of dentine, which will not allow the straight line path. So if I try and put my DC16 explorer, I'll get the canal orifice. but it will not go inside nicely. If I place 10 number K file, you can see the file is bending because of the shelf of the dentine. There is a curving of the file. And if I use the SX, which is the orifice opener, you can see now that shelf of dentine is removed, and now you can go ahead with the shaping of the root canals. Avoid shaping toward the inner surface of the roots. The red dotted line is the inner surfaces of the roots where there is the permanent tooth bud which is accommodated. And this stripping in this area can cause a lot of complications because of the leaking of the irrigation agent as well as obturation material that can deflect the path of eruption of the premolar. So avoid these danger zones. If you are more interested in learning about this, I would recommend the 41 chapter on pediatric dentistry principles and practice by Dr. M.S. Muthu and Dr. Shivkumar sir. The chapter's name is 41 Microscopic and Rotary Endodontics. Now, before obturation, maintain good isolation. There should be no bleeding from any canal after final rinse with 2% chlorhexidine. Sterile absorbent points used for drying should be without any exudate or fetid odor. That means the canal, once you remove the paper point, it should come out dry, and at the tip you smell it and you should not get the fetid odor. The dispersion tip of the obturating syringe should be loosely fitting in the canal. The rubber stop should be adjusted 2 to 3 millimeters short of the working length so that there is no chance of extrusion. Remember, if you use the apex locator, there is least chances of over obturation. If you don't use it, if you use radiographs for length estimation, you will end up causing a lot of over obturation cases, and that is detrimental in your final exams, practical exams. Now, as far as the obturation materials and the methods is concerned, I'll recommend these two articles. One is way back presented by Dr. Omar Bawazir and Fawd S. Salma in 2010, and that is clinical evaluation of root canal obturating materials in primary teeth. You can make a nice simple chart which is there in this article. Also, another article by the Indian authors, Dr. Srikant Kumar Malineni and Dr. Shivkumar sir again, and Dr. Raj Shekhar. It is on obturating materials used for pulpectomy in primary teeth, a review. This is a free article to download. You will be able to download it very easily, and you'll get all the information which is required. I want to thank Dr. Madhu and his team of Virtual Pedo Rapid Revision 6th edition for giving me this opportunity to speak, and of course the ISPPD head office for involving me in this event. Thank you very much. And these are my contact details. If you have any difficulties, my mobile number is there. You can contact me later also. No problem. Thank you so much. Have a good day and good learning.
The students have a lot of very good presentation, sir. Students have a lot of questions to ask you.
Yes.
I'll be selecting few of them and I'll be asking you, why is propylene glycol used as a vehicle and the reason for it? Can saline be used as an alternative to it?
Saline can be used if you don't have propylene glycol or macrogol, but those agents which I have mentioned, they are recommended by the original authors who have mentioned the use of the triple antibiotic paste. Okay, so that is why saline is not recommended. Saline, you can use it if you don't have any option, just as a carrier, but the absorption of these antibiotics is better if you are using it with the propylene glycol or macrogol.
There's a question, probably their seniors must have, the examiners must have asked their seniors, so they have directly posed the same question here, asking the best observation material for pulpotomy in 7-year-old child, zinc oxide or endofloss, and how to justify it.
7-year-old, I would prefer to use something like calcium hydroxide iodoform, because even if it resolves faster, the tooth is not going to stay there in the mouth for a longer duration of time. For the younger children, I would prefer using zinc oxide eugenol based materials. For elderly children, I would prefer to use the materials which are calcium hydroxide iodoform paste combinations. You can do combination of both also.
What are the methods to determine working length for resorbed canals?
For working length determination of
Resorbed canals.
resolved canals, you can detect only by apex locator and not by radiographs. Radiographs will always give you overestimation. If you know the amount of infection also, you see more on the radiograph as compared to what the rule we have been told that you will see that 30% there is more involvement clinically as compared to what you see on the radiograph. So please apply the same principle for root canal estimation of the length also if you're using the radiographic option. And apex locator is not that expensive nowadays. The prices have reduced and there are integrated motors which are available in the market with apex locator which are lesser than 50K. So it makes a better option to go for them. That is what is my personal recommendation. You will rarely see any over obturation cases if you use apex locator. Otherwise, you will see it on almost every case. You will see over obturation if you're using radiographic length.
And this next question is recommended shaping technique for primary dentition, which quite a few people have asked. And attached to that, they've asked preferred shaping technique. In
Shaping
primary
technique,
dentition.
the hybrid techniques are the ones which are most commonly used. This is what I use. Use the glide path shaping is done with the hand files, 15 number and 20 number, 10 number negotiate, 15 number, 20 number, create a glide path and then shift to the rotary. So that is the hybrid technique. Also, the crown down technique is much easier and much more easier to learn also. So you can use that. In permanent teeth, I use crown down technique. But for some reason, you'll find a lot of studies in the literature where the step back technique is more predominantly recommended in the literature. But clinically, I don't find that technique that useful. I would prefer to use the crown down or the hybrid technique. Thank you, sir.
Last two questions I would like to ask. Why heat treated files are better than stainless steel files?
Because of the the memory, the shape memory effect. They will come back to the shape much easier. They are much more flexible and less likely to separate if you follow the recommended number of uses of those files. That's why the heat treated files are better.
There's one more question as what is rest treatment, R-E-S-T, rest treatment?
Rest.
This has been asked in a couple of university papers.
I have not heard of this.
Okay, well,
not heard of this.
and the last one, suggested obturation technique for long roots and in case of calcified canals.
For long roots, suggested obturating material, I would prefer using paste system in the form of.
So your voice is not audible.
I would prefer to use zinc oxide eugenol because in the longer canals I can use lentulospiral and I'll make sure that the obturation material will reach there.
So there's still a lot of questions going on, sir. It's come to 75 questions. Like, I think we'll be running short of time. Definitely.
No problem, sir. I will answer all the questions on the chat.
Yeah. And the students, all that they have asked certain references and all, we'll send it to you. I think the students can get it later when you get it.
Once I submit the PDF, there are references which are already there in the presentation, and I will also suggest some more references from my archives. Thank you.
Yeah, thank you, sir. I request Mr. Dev to please project the certificate of appreciation to Dr. Prasad Musale.
Thank you very much, sir. Thank you very much.
Thank you, sir. Thank you, sir. Now I request Dr. Nikhil Marwah to please introduce the next speaker, Dr. MaheshRamakrishnan.
A very good afternoon, good morning to you all. Good morning, Mahesh. And I hope
So good morning.
that presentations till now have been, really elaborate and really comprehensive. In fact, Virat's presentation was a peppered one, and Prasad sir's questions were like bombarded. I think you got both the questions together. विराट के भी और आपके भी दोनों इकट्ठे आपको मिले. But going on to the next session, the next speaker is Dr. MaheshRamakrishnan. He is Associate Dean of Hospital Administration in Savita Dental College and Hospital, and he is also a NAC assessor. He has been an active contributor to, in the form of, various editor posts in IDA. He is the branch executive member of ISPPD and has numerous academic and research contributions in Savita. And I'm sure he can elaborate on this allotted topic, and you will have a great listening. Over to you, Mahesh.
Thank you so much, sir. Thank you so much. My screen is already. Good afternoon, everyone. I'd like to thank ISPPD and Madhu sir from KLE Bangalore for giving me an opportunity to talk on this topic of Apexification and regeneration. When I started preparing this topic, Madhu sir gave me a template. So he told me that the first slide should have an introduction of the speaker. So rather than typing about me, I thought, why not ask AI, who is MaheshRamakrishnan? So I went to AI, I asked, who is MaheshRamakrishnan? So based on AI, it says that Mahesh holds an MDS and PhD from Savita Dental College, is an associate professor, and currently is the Associate Dean of Savita Dental College and Hospitals. So moving on to our topic, my topic is on apexification and regeneration potential as such. So start with an eruption. If you define an eruption, eruption is movement of your tooth from its developmental position to its functional position as such. So that we termed as an eruption. A tooth usually starts erupting when the 2/3 of the root length is formed. So it starts erupting, then it comes to the oral cavity. So after it comes to the oral cavity, there's something called as your post-eruptive maturogenesis, where the enamel gets more matured, the root development is still getting formed as it. So it takes a time period of 2 to 3 years of the time frame for the root to completely develop after it comes to the oral cavity. The crucial period of this 2 to 3 years of time, any impact on the pulp tissue on this period of 2 to 3 years of time can affect the root development. So that is where your treatment protocols such as your apexification or regenerative procedures comes into play. We see this landmark article. This is the first landmark article published in 1933 in JADA that shows the each stages of complete tooth eruption. So for a tooth to erupt, what is the major thing? The major thing is your vital pulp. So if you maintain a vital pulp, so that's going to help your immature tooth to complete root development. There's a pulp which also contains the odontoblastic cells, which are specialized cells to form your dentinal structures. The pulpal tissues also contain certain immunocells that are going to protect the pulp from any kind of irritation which can happen because of trauma or exposed to salivary fluids, or it can be because of caries. If the pulp becomes non-vital due to any factors, either it can be because of the trauma or it can be because of a consequence of caries, then the tooth becomes more susceptible to any kind of infection. If the tooth is susceptible, then probably the root development is going to be affected, and also the dentin deposition is going to be affected in a non-vital pulp therapies. So what can happen? What is the consequences of, what is the etiology of this pulpal pathology? The most common etiology what we see is caries. In some cases, it can be because of trauma, and in maxillary lateral incisors, as you see a developmental abnormality such as a dense dentines can also lead to a infected and a necrotic pulpal tissue. If we see a necrotic pulpal tissue, in that case, if the root canal and the apex is closed, then probably we can do a conventional root canal treatment. The conventional root canal treatment has got a more success rate in a closed apex tooth rather than your regenerative endodontic procedures. So if the apex is closed, the root has got an adequate root length, then probably you have to go ahead with the conventional root canal treatment in a necrotic pulp rather than trying with an endodontic procedures, trying with a regenerative endodontic procedures. If the root canal is still not closed, the apex is still open or a blunderbuss canals, then probably we can try either an apexification or an regenerative endodontic procedures. The apexification procedure is a traditional treatment modalities for an immature permanent tooth with pulpal necrosis. So what are the difficulties which we can encounter when we see a pulp, when we see an immature tooth with an incomplete root? There are basically four different difficulties which we can encounter when we see a immature tooth which has got a necrotic pulp. The anatomy of the tooth is going to be very complex. You will see a very, very short root length. The crown root ratio is not so favorable. The root dentin wall is going to be very thin. So in some cases of repeated fractures, or if you try doing a biomedical preparations, we will end up in fracturing the thin root canal. And at the end of the day, if you're going to obturate the tooth canal using a gutter pitcher, we will not be able to get a proper seal. The GP flows beyond the apex, causing a periapical lesion. So we don't have a proper apical seal. So if you're seeing a case when a patient comes to you with a non-vital or a necrotic pulp with an open apex, how do you go ahead and do it? So initially we test the vitality of the pulp. So vitality testing, there are basically two types of vitality testing. Either you test using a thermal test or electric pulp, or your other vitality test like your blood flow of it. The thermal test, it activates the hydrodynamic movement of the fluid within the dentinal tubules, which is going to excite your A delta fibers. But these two thermal testing, either it can be hot or the cold, or your electric pulp testers are not much reliable in a very young children, because the response from the children may not be much reliable in that. So we have another vitality testing methods such as your blood flow of your pulp using laser Doppler flow multi, much more reliable than your sensibility testing. So the sensibility testing can tell you an indication that the pulp is damaged, so it may or may not go for necrosis. So moving on to the other type of testing, such as your vitality testing. Vitality testing has got many different types. We have your laser flowmetry, ultrasound, pulse oximetry. So this basically determines the blood flow of the pulp, so that are more objective rather than a subjective response from a pediatric patient when you do this on a pediatric population. So according to many studies, they share that the vitality testing method is more superior and are more objective approach rather than your sensibility testing methods. But still, vitality testing also has got a lot of bias, probably in a very young population, and a tooth who has recently been traumatized, because the response of the pulp may not be reliable for both kind of testing method. The pulp is in a state of shock. So the response from, and even from the in an immature child, probably the response is going to be variable when we do all this pulp testing method. And according to Anderson, the immature tooth is not fully innervated, and maybe an increased excitation threshold is also there. And if you take up the color changes of the tooth as an indication, probably that is also more biased. A discolored tooth may not indicate the complete status of your pulpal pathology. So this is one treatment flow diagram which shows you what all treatments can be planned when we see a teeth with an exposed pulp or in a fractured case. Say if it is an uncomplicated fracture, it is only involving the dentin and the enamel, probably we can start using a enameloplasty or a mild composite restoration should be sufficient. Say if the patient is reporting immediately with a vital pulp, say probably then we can try doing an indirect pulp capping, or if or within 24 hours, probably we can try doing a pulpotomy procedures. If it is a minor infection, we can try doing a civics pulpotomy, or in deeper cases, a full coronal pulpotomy can be tried. Or if the patient is going to report to you a long time after your trauma, the tooth has become a non-vital tooth, we see an extraoral swelling with an incompletely formed root and a blunderbuss apex, then we have to go ahead and do some regenerative procedures or apexification. Regenerative endodontics is indicated for a partially formed root with a wide open apex, whereas an apexification can be tried at the end of the root closure, patient who is coming with a non-vital tooth. So apexification can be two methods. Either it can be done in multi-visit apexification using your gold standard calcium hydroxide, or a single visit apexification using an MTA or biodentine or any bioceramic seal. And then if the fracture line is beyond the CEJ, then probably we can try doing an orthodontic or a surgical extrusion, or if you see a vertical fracture or multiple fractures, then probably with a very young tooth, it is going for an extraction. So what can expect from all these regenerative procedures? It is divided based on 3 criteria. What the patient expects. For the first, the patient expectation is always like the resolution of the disease. The patient is free from any kind of swelling, or the tooth is stable in the mouth. The tooth survival and function is there. Since it is an anterior tooth, the aesthetic is there. The patient is happy. If we take from the clinician point of view, the treating doctor is more happy if the success rate, the radiograph is going to heal better. There is a continued root development which is happening place when you see it on the follow-up appointments, and the tooth is positively giving a vital response. So these 3 are the categories where a clinician point of view, he is happy in all his regenerative procedures when he see all these 3 points. But when we move on to any research materials, the researcher is more happy if he see an evidence of the pulp genuine complex, which is regenerator assay. So that is the core concept of this regenerative endodontic procedures. So if you take up any partially formed tooth, this regenerative endodontics, there's one classification which we have to remember. One is your civics classification. And it was proposed in the year of 1992. It has got 5 stages. The first stage, what we call it as when the root is only less than half of the root is formed. The second stage, where we see half of the root is formed. The third stage is the 2/3 of the root is formed. The last one is the root is nearly formed. And the first 5 is the fully formed tooth. So if you take up the schematic representation, this shows the civics 5 stages. So the treatment protocol for stage 1, 2, and 3, it is ideally better that you do a regenerative endodontic procedure, since the root canal is very short, the crown root ratio is not much favorable, the dentinal wall is very thin. So these cases are more indicated for a regenerative endodontics procedures rather than a apexification procedure. Say a stage 4, the apex is almost closed. We have got a favorable crown root ratio. The apex is very little open. Probably those cases, we can try either a revascularization procedure or an apexification. Whereas the stage 5 of civics says that the apex is completely closed. It is a completely fully formed tooth. So this is indicated for an conventional root canal treatment. So what is an apexogenesis? Apexogenesis is a physiological method which is done in a vital pulp. So the pulp is vital. We either do a pulp capping, a direct or an indirect pulp capping, or we do a pulpotomy, civics pulpotomy, or a full pulpotomy. You maintain the vitality of the radicular pulp so that the physiological development of the root happens as such. So that we call this an apexification, apexogenesis. What is an apexification? Apexification is an artificial method where you create a barrier at the apex. For that, your obturating material has got an NF stop. So this is done most probably in a non-vital necrotic pulp, where the pulp doesn't have the capacity to regenerate and the root development is still incomplete. So you keep an artificial material at the apex, close the apex so that you get a apical stop, and then you proceed with your conventional root canal treatment. So that's called as your apexification. So this is the basic difference between an apexification and an apexogenesis. Apexogenesis is done for a vital tooth using a calcium hydroxide or an MTA, pulpotomy, pulp capping. So all those procedures where the vitality of the pulp is maintained, it happens as a physiological process. So the root still keeps growing and the apex is completely closed. Whereas in apexification, it is most commonly done on a non-vital tooth. The tooth is necrotic. The tooth doesn't have a capacity to complete the root formation. So we do an apexification procedure. Apexification can be done using a calcium hydroxide, which is the gold standard, and it is a multi-visit calcium hydroxide apexification or a single visit MTA apexification. So we do a mechanical closure and then we obturate with Gatapaka. So this is the basic difference between both the most commonly used apexification materials. Economical ones, calcium hydroxide is better. Both are alkaline. Calcium hydroxide is more antibacterial. It stimulates apical formation, but the disadvantages, you have to keep repeated changing it. So the apical formation can take a time frame of 6 months to 2 years for the root closure. So it is a very slow process. You tend to see the patient on a multi-visit process. So that is the major disadvantages of using a calcium hydroxide. And there are a lot of studies which says that multi-visit intracanal medicament of calcium hydroxide can causes your root fracture. The roots become more prone for fracture. So to shift that, we have your MT apexification, which has got an excellent sealing ability. and it is mostly a single visit apexification procedures. So this is how the mechanism of action of your calcium hydroxide. When we get a calcium hydroxide, it segregates into calcium ions and the hydroxyl ions. So it increases inhibits the pyrophosphatase action and leading to mineralizations. So calcium hydroxide has got an antibacterial properties. It neutralizes your lactic acid of your osteoclasts. It stimulates alkaline phosphatase to induce your calcification to produce a dentinal bridge formation. So what happens if an MTA comes in contact with the tissue? The MTA is also alkaline. It provides a good environment with a higher pH. It modulates your cytokine production. It encourages differentiation of hard tissue producing cells, forming an hydropy of apical barrier to create for you. So this is one basic advantage of MTA. The MTA is very less soluble. It is non-permeable and it is a non-resorbable material. And the apical closure in an MTA is more good and reliable rather than an calcium hydroxide, which is more unpredictable. So the advantage of MTA is it is a very superior material and a biocompatible material, and it is currently the favorable choice for any apexification procedures. So it is to stimulate the development of new mineralized tissue. To come to the newer concept now is your biodentine, which is also a calcium-based silicate material that is also used to form an apical barrier. The biodentine, the advantages of biodentine is the biodentine sets much more faster than your MTA. Since MTA apexification, the initial setting time of MTA, it takes at least 2 to 3 hours of time, whereas the final setting time, it takes at least a minimum of 24 hours. To overcome this advantage, we have a biodentine, which is a recently introduced material. The initial setting time is only 12 minutes. So, okay, you can finish it off your apexification and your obturation in a single visit for a biodentine, whereas in an MTA, we usually tend to do an apexification in one visit and then the obturation in another visit. So biodentine is the most commonly used material now. It has the composition of calcium. A composition of biodentine includes your calcium carbonate, zirconium oxide, tricalcium silicate, dicalcium silicate, and calcium hydroxide. So if you're reading about this regenerative endodontics, there are a few terminologies which you have to define when you're writing a paper on regenerative endodontics. The first and the foremost terminologies which you have to know is your apexification. So apexification, as you defined by Rafter in the year 2005, that is one landmark article which you have to read when you read about this apexification procedure. It was published in the year 2005 in Dental Traumatology. He defined apexification as an endodontic procedure for immature permanent tooth with necrotic pulp aiming to induce apical closure and allow for your conventional root canal filling. The obturating material can be your calcium hydroxide or an MTA, which is used to create an apical barrier. So then the next one would be your necrotic or your pulp revascularization or your regeneration, revitalization procedures. This revas can be revitalization or a different concept as such, but both of it is going to revasculate. The bleeding is going to form in your pulp chamber, thereby promoting your tissue formation. So you induce the bleeding, you create a favorable environment for the root closure. So that we call it as your revascularization.
I'm not able to hear.
Uh,
Sir, there's an issue with your network, I think. You're not
no
audible.
problem. No problem, no problem. I think Mahesh will rejoin. Don't worry. Sometimes it happens. We can wait. Yeah, he will reconnect with us. That's okay. Yeah, he's back. Hi, Mahesh. Welcome back. No, you are muted, Mahesh. You are muted. You need to unmute yourself. Just unmute yourself. Mahesh, you need to unmute yourself.
Yeah,
Maybe.
yes.
Yeah. That's okay now.
Okay, what we are talking about is regenerative endodontics. Regenerative endodontics is where we still do revitalization, but
we need to
keep
share the screen again. Screen is not visible. Presentation is not visible. Yeah, absolutely fine.
So what next topic what we see is your regenerative endodontics. In regenerative endodontics, what we use is we need a scaffold as such. So you have to induce your bleeding. You keep a scaffold or a biological procedure within the root canal for the tissue to promote for. The regenerative endodontics is a newer concept where your blood vessel is going to form your pulp dentin complex, a whole pulp dentin complex with an innervation also. And the deposition of mineral is going to happen, and the strengthening of your dentin walls and growth of your root apex is going to happen in regenerative procedures. So what are the steps in a regenerative procedures? We have multiple steps. The first indication for a regenerative procedure is you always do this regenerative procedure in a permanent tooth and a very immature tooth when the apical foramen width is more than 1.1 mm. And the pulp is going to be necrotic. If the tooth is going to be benefited out of your regenerative procedures, then you do a regenerative procedure. If not, the root is a complete closed root, then you do a conventional root canal treatment that is more reliable rather than doing a regenerative procedures. The anesthesia, we always prefer doing without a vasoconstrictor. And the first stage in this phase is disinfection of your root canal. Since the patient is coming with a necrotic pulp, it is already an infected pulp. This is the first stage in regenerating procedure is you disinfect the canal. So you irrigate the canal with 1.2% of sodium hypochlorite. You determine the working length. You tend not to avoid doing an instrumentation on the dentinal wall because the dentin wall is already thicker, already thinner, and you pack the canal with an intracanal medicament. The intracanal medicament can be a calcium hydroxide or a triple antibiotic paste or a double antibiotic paste. So you keep this intracanal medicament for one setting for 4 weeks of time. If the symptoms has come down after 4 weeks of time, then you proceed with the regeneration. Other not, in that case, you do one. If not, you do another intracanal medicament for another 4 weeks of time. So the second visit when the patient is coming, so probably this is where we do a irrigation, chelation, and rinsing of your root canal. Chelation, we use 17% EDTA for 60 seconds. And then your final rinse, you induce bleeding from the apex using a K5. You let the blood fills the root canal, and then you keep 2 mm of MTA. And if not, if you are doing a scaffold, you keep a scaffold and close the tooth. And then you monitor the tooth for 6 months period, whether the root generation is happening or not. And then for a longer follow-up till the root completion has happened. So this is one schematic representation which shows you the procedure, the 2 stages in any regeneration procedure. The first stage, we do an access opening, determine your working length, prepare your canal, irrigate with sodium hypochlorite, and then dry the canal. You keep an intracanal medicament and close it off. When the patient is going to come back to you for the next visit, then that is you remove medicament, dry the canal, induce the tooth for a long-term prognosis. So endodontic root canal, definition of an endodontic root canal, it is a biological based procedure to replace the damaged tooth structure, including your dentin and the root structure and a pulp dentin complex. The concept of regenerative endodontics was proposed by American Association of Endodontics in the year 2007. So the regenerative endodontic procedure cites all the procedures which is going to do an organized repair of your pulp dentin complex. All the procedures which are currently doing, and probably in the future also, what all procedure we are going to develop for the pulp dentin complex, all these procedures comes under your terminology of your root regenerative endodontics. The concept of regenerative endodontics, the first case was described by Nikhil in the year 1961. So he proposed the term of regeneration, revitalization, but the concept of using a triple antibiotic paste for regeneration was proposed in the year 2004 by Trope. He developed this protocol for regeneration using a triple antibiotic paste. So what is the difference between a pulp revascularization and a pulp regeneration? In a revascularization, the pulp is the angiogenesis only is established. The population of the cells which is formed in revascularization may not be an odontoblast cells, but in some cases we tend to see an increased root thickness, continued root development, and something like a pulp-like tissue is formed in revas pulp tissue. Limitation, it may not fully restore the pulpal functions, such as your nerve endings may not be fully established, complete dentin regeneration may not happen in a pulp revascularization. Whereas in a regeneration is a completely an addition to revascularization, where you introduce a scaffold or a biological procedure into the root canal. So that develops and deposits the minerals and growth of your immature tooth. So the basic difference between a revasc and a regeneration is, in regeneration, you need a scaffold or a biological procedures to keep it inside the root canal. See the outcome, if you take up the outcome of any regenerative procedures, there are multiple case reports which I will be showing it in the next slides. But the pooled success rate, they show that the healing capacity is almost 97%, but it is not so definitive conclusion on the predictability. There are not much systematic reviews or long-term prognosis to say the regeneration will definitely have a better outcome. So what is the advantage of regeneration? It is alternative to your apexification. Since an apexification, we only create an apical stop. We don't make the dentin to grow on the root walls. The root wall is still fragile. There are chances that it may fracture in a long time. When you do a regenerative procedure, the dentin wall is going to become much more thicker. The root is going to continue to grow it. And then the apical lesion and continued root development is one advantages of your regenerative procedures. And if you're doing a regenerating, the nerve ending is also going to be established, so it can restore the sensitivity of your tooth. So the take-home point is, never do a regeneration on a fully developed tooth, because in a fully developed necrotic tooth, a root canal has got a better prognosis rather than your regenerative procedures. Consider doing a regenerative procedures only if you see an immature tooth with a necrotic pulp. In those cases, the dentinal wall is very thin. A conventional root canal and apexification is not possible. So doing a root canal is more beneficial for the patient in those cases rather than doing an apexification. Those are the cases which is indicated for a regenerative procedures. And never use a full form of sodium hypochlorite. It is always better that you dilute sodium hypochlorite to 0.5 to 1.5 concentration of your sodium hypochlorite. And if they take up this regenerative procedures, there are three important factors which is the most important thing in any regenerative procedures. You need a scaffold, you need a stem cells, and you need a signaling factor. So these are the three important things when we plan for any regenerative procedures. So regeneration, the goal of your regeneration is to absence of any clinical symptoms. We see a good bone healing, increase in your root length and the root wall thickness, and a positive pulp vitality testing. So these are the major three goals when we do a regenerative procedures. So this is one schematic representation which shows you the basic three things when we plan for a regenerative endodontic procedures. So we need a cell, we need a scaffold, and we need a signaling pathway. So all three of this collaboratively will help in establishing your pulp dentin complex, so that take care of the next generation of root canal, completion of your root canal and your apical closure. So scaffolds, the scaffolds is also one short notes. Scaffolds can be a naturally derived scaffold or a synthetic scaffold. We have inorganic foams, fiber, gels, mesh. So there are multiple scaffolds which we can use it in regenerative endodontics. Cells also, we see a lot of cells, stem cells from periapical papilla, stem cells from dental pulps. So multiple stem cells also can take place, which helps in your regenerative endodontic procedures. So what is an ideal scaffold? If you take up the properties of a scaffold, the scaffold is the one where the cells and the signaling molecules come there on a scaffold, they stay on the scaffold. So the scaffold should provide a biological and mechanical support for your stem cells. It should provide an environment which is conducive for cell addition, migration, proliferation, and then your differentiation of your stem cells to a specific osteoblast cells. And then the scaffold should also provide nutrition for these cells, oxygen, and then metabolites. So once the function of the scaffold is completed, the scaffold should degenerate consistent rate with that of your tissue generation. So these are the basic four properties for any kind of scaffolds which you are using in this regenerative endodontics. The most common scaffolds which we use is your PRP, PRF, and your blood clots. So these are the most common scaffolds which we use it in this regenerative endodontic procedures. So this is one tabular column which shows you the dental pulp. What all stem cells can be derived when we do this revascularization or regenerative procedures. And this stem cells has got the potential to differentiate into what all cells type of. If you take up the dental pulp stem cells, it can transfer into your odontoblast, osteoclast, adenocytes. So these are the properties. These stem cells can differentiate to the other form of cells. So this is one method of revascularization where we introduce some PRP and PRF for the root to elongate. So this is the process which we commonly do. We induce the blood clot and then we allow the root to establish the pulp dentin complex and then the root development. And next week, one more concept of cell homing. Cell homing is a process by which both the stem cells, the endogenous and the exogenous stem cells, migrate in a specific tissue. So we create a location where the cells is going to migrate to us based on the chemical signals. So we provide a scaffold and the growth factors so that the stem cells from somewhere location migrate to the stem cell and they form a dentin pulp complex for the regeneration. So that is the concept of cell homing. Cell homing, we just provide the scaffolds and the growth factor. So the stem cells will migrate from some other location to the scaffolds and then they probably based on the chemical signals and then they develop the pulp dentin complex. And the last one is your cell-based PRREPs, where you provide the cells also, the scaffolds, the environment, complete environment for the pulp dentin complex to form, which is going to help out in the regeneration process. So this is the schematic diagram which shows the difference between your cell homing strategy and your cell transplanting strategy. When cell homing, you just provide the growth factors and the scaffold. So the stem cell is going to migrate from some other location based on your chemical signals. They come here, they grow, they differentiate, then they establish a pulp dentin complex. Whereas your cell transplantation is you keep all the three factors. You keep all the three inside the canal so that it differentiates and then it forms the pulp dentin complex. So these are the basic advantages between your stem cells advantages and disadvantages of all the three procedures: stem cells, pulp, scaffold, 3D printing, injectable scaffolds, and your gene therapies. And this is one tabular column multiples which shows the multiple studies on the effect of your intracanal medicaments on the scaffolds. Say the most common intracanal medicament which has been shown in most of the studies is triple antibiotic paste. And the common scaffold which they used is mostly they use still blood clot. In some cases, they use a PRP and a PRF. So this is the study and the results of multiple studies which has been done in the previous literature using a intracanal medicament, scaffolds, and the observation period, how long it took for the regeneration or the root development to happen. So this is also based on the intracanal medicaments and the scaffolds on regenerative endomodeling and what is the significant results of all these studies which have been conducted and what is the time frame. So it took at least a minimum of 18 months to 3 years for the root development to complete when we do with a triple antibiotic paste and a PRP material using an MTA capping material. So this is the long-term follow-up of the case report which is there in the literature. So if we take up which is the better scaffold and most commonly used scaffold, blood clot is the simplest approach. This is the most common scaffold which we use it in our regular practice, but the limitation is that we will not be able to induce bleeding from the periapical region. We induce bleeding with a K-file, but we see in some cases the blood is not completely filled near the CEJ. So that is the one limitation when we use a blood clot as a scaffold for this regenerative endodontic procedures. And then we started withdrawing the blood. We did some PRP procedure. So PRP is a natural scaffold. It reduces the risk of cross-infection and immunogenicity. However, it is not entirely an autologous. PRP releases growth factors, but that quickly goes off in a time frame of 7 to 4 hours. So after 7 to 14 hours, the growth factor release from a PRP is going to be very less. In that process, we came up with a PRF. PRF is introduced as a regenerative procedures to address the limitation of your PRP and your blood clot. PRF not only enhances the release of the growth factors, but it offers a completely autologous composition. So it has got a sustained slow release for 14 days. PRF is more cost effective and it is easily to prepare in a clinical setting. And it has got more advantage compared to that of your blood clot and your PRP. So this is the follow-up cases which have been published, which shows the stem cells and the effect of the irrigation solution on the stem cells. Say if you're using a higher concentration of an irrigation, say more than 1.5% of sodium hypochlorite, what is the effect of that particular solution on the stem cells. So higher concentration of sodium hypochlorite or chlorhexidine has got a negative effect on the dental pulp stem. So it is always better that you use solution with a minimum concentration. Say the recommended concentration, the protocol says that 0.5 to 1.5% concentration of sodium hypochlorite is indicated for any regenerative procedures. And then chlorhexidine is not indicated for any regenerative procedures. So if you take up the indicated, the desirable and the undesirable solution, so these are the desirable solutions for any regenerative endodontic procedures. We can use 17% EDTA, 10% citric acid, 0.5 to 1.5% of sodium hypochlorite can be used for a regenerative procedures. Whereas the contraindicated is higher concentration of sodium hypochlorite, chlorhexidine. So all these are contraindicated for a regenerative endodontic procedures. So if we take up the effect of the intracanal medicament, what happens when we keep an intracanal medicament on the pulp stem cells? Actually, what is the effect of intracanal medicaments on the pulp stem? The higher concentrations of triple and the double antibiotic paste also have got a negative effect on the pulp stem. So it is always better that you don't use much high concentration of triple antibiotic paste. So everything when it is a minimal effect, so that promotes the dental pulp stem cells to grow, whereas an higher concentration has also always has got a negative effect on the pulp stem formation. So what are all the complications which can happen when we do a regenerative endodontic procedures? The most common complications and the three complications which we can encounter is the first thing is the pain. The pain can be an intermittent pain or when we are doing the procedures, or the tooth coloration. Since we are using a triple antibiotic paste, sometimes it can cause discoloration of the tooth canal, or in some cases we can get an intracanal calcification. So these are the three most common complications which we can encounter in our regenerative procedures and how it can be prevented: tooth discoloration, intracanal calcification, and the pain. So what is the advantage of a regenerative procedures? The regenerative procedure is technically sensitive procedure. It is actually a very simple procedure. It preserves your vital tissues. It has got more regenerative procedures. But the disadvantages is the prognosis is not much reliable. We don't know whether the root development is going to happen or not. The outcome is not much reliable in a regenerative procedures. And what is the prerequisite of all these procedures is we need a necrotic pulp. We do this revascularization procedures only if it is favorable, that we need the root to develop. The crown root ratio is unfavorable. It is only till the middle third the root is formed. The apex is very wide open. We will not be able to keep an apexification or an MTA procedure. Those are the things where we do a revascularization procedure. If it is a very small apex is still mild open, in those cases we try to do an apexification, which is more reliable rather than doing a regenerative endodontic procedures. And if it is a fully developed tooth, then root canal is always better rather than trying all this regenerative endodontic procedure, because the number of visits the patient has to come, the reliability of this success of this regenerative procedures may not be predictable when we do in an impermanent tooth. So this is one tabular column which shows you the most common treatment procedures which we can encounter. If you're seeing an immature tooth, if the apex is still closed, we will do an RCT. If it is a mild open apex, then apexification can be indicated. If it is a very wide open, then probably we have to do an endodontic regeneration. Steps in endodontic regeneration is you disinfect the canal, you do instrumentation, you do a filing, you keep a scaffold and a thin layer of MTA, and you monitor the tooth for a long term until the root apex is getting close. So the long-term follow-up, the patient complaints is the main important factor in any endodontic regeneration. You need the patient for a long follow-up, probably for a 2 years of follow-up, to see whether the root completion is happening or not. So that patient complaints is one critical factor for any regenerative procedures. And most of the cases, some cases, if you're going to convince your patient, the reliability, we will not be able to know whether the treatment, how the tooth is going to respond, whether the treatment may or may not lead to a root closure. So the reliability of the treatment is also questionable. So, and patient complaints is also the most important factor when we do this regenerative procedure. So that is where you say, your case selection is more important, where I want to do for a regenerative procedure, or I'm happy with doing an apexification, or if it is a completely full developed tooth, then probably a conventional root canal is always better. So scaffolds, we saw multiple scaffolds. So what is a best scaffold? So there's one systematic review which says that the intracanal scaffolds used during RCT does not have a significant difference in the clinical success. The scaffolds doesn't matter on the clinical success and the root canal maturation and the pulpation. So there is less effect on the from the scaffolds on this clinical success and root canal maturation and pulp sensitivity. So when we were studying 20 years before, we had multiple books to study. So in those cases, when we take it up, we always have this thought of two schools of thought. If you take up fluoride also, whether to go with fluoride or whether not to go with fluoride, we always had these two schools of thought. But now the problem is we have multiple schools of thoughts. So if you want to take up any references for your studies or your essay questions, it is better that you take it up as standard journals, such as your IJPD, JOCPD, or JSPPD. So some standard dental journals which publish on that particular category. And it is always better that you take it up an association guideline, because all this regenerative, apexification, or your root canal, there is an association which tells you of these are the particular guidelines which can be used and what is the protocol in all these things, rather than, because what problem currently we see is there are multiple journals, multiple systematic reviews on particular topic itself. The conclusion may be different on all topics as such. So it is always better when you're taking up something for your reference, you always take up from a standard journals and a standard association which deals with that particular topic. So if you take up an association guidelines, we have a lot of AAPD guidelines which tell you about all these protocols for revascularization, AEI or dental traumatology guidelines, explaining you, so what is the protocol, how it is used, what is the consequences of it. So it is always better that you follow the association guidelines or some standard guidelines before you take the particular topic for your thesis or your reference writing. So while preparing this PowerPoint presentation, I came across the most common and the useful topics, 6 basic research article which can be used for your further studies. The one which talks on endodontic journal on apexification, the particular articles will tell you about the outcome of guided generation, how we are planning for a regenerative approach, and what do you mean by tissue generation and what are the consequences of it. And then if you want to read more about this apexification, it is always better that you read this article on Rafter in the year 2005 on dental traumatology. This article will tell you about all those apexification, the definition of apexification, what is the width, what is the length material which you have to keep, what materials are currently available, how the material is going to help in your apical closure. All those is detailedly explained in the apexification review in Rafter in 2005. And then if you want to read about your scaffolds, there's one recently published in 2023 in Journal of Endodontics based on the scaffolds for your regenerative endodontics. And then to read more of your PRP and PRF, it is always better that you read one in British Dental Journal in 2025, the regenerative potential of your concentrated growth factors to platelet-rich fibrin fat. So this will also tell you about more of the properties of each material, when indications where all we can use those particular materials. And then the last one which I came across when preparing is one on 2025 in International Endodontic Journals, which tells you more about this dental pulp stems, the signaling molecules, the scaffolds which can be used for any regenerative endodontic procedures. To conclude, so what all questions can be expected when we are preparing this regenerative endodontic procedure is, the first thing which we can expect is your materials. Since the material evolution is going to happen, so what are the newer materials which we can encounter in this apexification? So biodentine, the MTA was replaced completely by biodentine because of the shorter working time. So the advantages of the newer materials in apexification. What is the clinical protocols in revascularization? How the protocols, what all protocols, the irrigants, what irrigants you have to use, what is the intracanal medicament, the effect of that particular intracanal medicament on the particular stem cells, what happens in that, what is the disadvantages, what is the advantages of using an apexification, and what is the advantage of doing and revascularization. So all these advantages, indications, and contraindications can be your essay and your short notes. And then we'll also importantly read about the scaffolds. Scaffolds in regenerative endodontics can be your essay, or it can be your short notes, such as like your PRP and PRF. The PRF and PRF concentration, what is the basic difference between a PRP and a PRF? What is the advantage? All this can be your short notes questions. So I'd like to thank ISPPD for giving me an opportunity. Wishing my best of luck for your exam, PGs. All the best for your exams. If you have any doubts, just mail me a file.
Yeah, there are certain questions that have been asked, Dr. Mahesh. The first one is apexification and apical barrier placement the same?
Sir, I didn't get you. Is apexification? I'll read up the question, sir.
Is apexification and apical barrier placement the same?
For an apexification procedure, we need an apical barrier as such. We have to create an apical barrier. The length of the apical barrier can be ranged from 3 to 4 mm of it. So usually the material of choice for any apexification procedure initially was MTA, but now people are shifting towards biodentine because biodentine has got a lesser working time compared to that of an MTA. So biodentine apexification and obturation can be done on a single setting itself, whereas in MTA, we need 2 settings for an MTA apexification, 1 setting. For an obturation, we need another setting to do it.
Thank you. Is root canal treatment recommended after regenerative procedures?
Sir, it is based on the clinical symptoms of the patients. If the pulp dentin complex is good, the patient is asymptomatic, the root is still completely grown up, then probably we can wait and watch and do it up. It is not mandatory that you have to do a root canal treatment after the apex is closed. The guideline says that it is only the long-term follow-up and the clinical symptoms which decide whether we have to do a root canal or not. It is not mandatory that you have to do a root canal after a successful regenerative procedures.
Okay. Is there any difference in the indications for revascularization versus regeneration? Indications, specific indications.
The revascularization, in that case, the basic difference is revasc and regeneration is, in regeneration, we use a scaffold. Currently, regeneration is the concept which is working rather than your revascularization. So regeneration, we need a scaffold, so it has got a better prognosis rather than your revitalization as such. So both of the treatment is indicated for a partially formed root. If the root is only 2/3 or the middle third of the root is formed, say in a civic stage of 1 to 3 is always indicated for a regenerative procedures. In that case, we tend to use a scaffold. So regeneration is always better than revascularization.
Last question, how to choose clinically and radiographically whether to go for a apical barrier technique or revascularization?
Sir, as I mentioned in my slide, in civics classification, we have 5 stages. So from stage 1 to 3, where the apex is wide open, the crown root ratio is not much favorable. That is indicated for a revascularization procedure. If the crown root ratio is favorable, we have an adequate dentinal wall thickness on the root. The apex is only mildly open. Those cases are indicated for an apexification case. If the apex is completely closed, the root is a fully formed tooth, then probably it goes for a conventional root canal treatment rather than you trying a revascularization or a regenerative procedure. So based on civic classification, 1 to 3 goes for regenerative procedures, 4 goes for apexification, 5 goes for a conventional root canal. So that, keeping that as a concept, 1 to 3 is your regenerative procedures, 4 is your apexification, 5 is your root canal treatment. So based on that, we can tell it.
Okay, sir. There are still many questions to be answered, and the previous 2 presenters have already answered most of the questions in question and answer box. So I request you to please go through the question and answer box and respond to them, because there are a lot of questions which probably we can't ask here because of lack of time.
Okay, sir. I'll do
many
it.
Students have asked for references, which probably the presenters will share, and we'll be sharing it with you.
Yeah, I'll share my PPT along with my references. As a PDF, I'll share it. But I think it's going to be available in ISPPD website also. Probably after the program overs, all these presentation along with the PDF will be available for all the students.
Thank you for the presentation, sir. I request Mr. Dev to please present the certificate of appreciation to Dr. MaheshRamakrishnan.
So thank you,
Thank you.
ISPPD, and thank you, Madhu, for the opportunity. Thank you so much.
So we'll be starting the next session sharp at 1 o'clock. Please log in at 12:45. And I request Mr. Dev to please present the certificates to the moderators, Dr. Nikhil Marwah and Dr. ShobhaFernandes.
Thank you, Madam. Thank you, everyone. And thank you, Dr. Madhu and his team.
I thank both the moderators for moderating this session. I request you all to join at sharp 1.
Thank you, Shobha Madam.
Thank you all.
Thank you all.
Yeah. We can close this session now, right?
Yes, we'll close the session. We'll
Yeah.
meet at 1:50. Sure.
Perfect.
Thank you. Thanks, everyone.
Okay, bye-bye.